and welcome to Endo Bites, Bite in Time, our short format podcast series where we discuss timely developments in endocrinology and metabolic health. I'm Kate Glasenapp, Assistant Professor, Nurse Practitioner in the Division of Endocrinology and Molecular Medicine at the Medical College of Wisconsin and co-director of our medical weight loss program. Today, we're discussing one of the most influential medications in modern medicine, semaglutide. Since its introduction, semaglutide has transformed the treatment of type 2 diabetes and obesity and has expanded into areas including cardiovascular disease prevention, as well as metabolic liver disease. Most recently, we've seen the introduction of oral semaglutide for obesity and higher dose Wegovy formulations, raising important questions about where semaglutide fits into the clinical practice today. So joining me is Dr. Vidya Kidambi. Dr. Kidambi is Professor of Medicine, Chief of the Division of Endocrinology and Molecular Medicine at the Medical College of Wisconsin, and co-director of our medical weight loss program. Her clinical and research interests focus on obesity, diabetes, and cardiovascular risk reduction. Dr. Kidambi, it's great to do this episode on hot topics in obesity and diabetes with you.
Yeah, thank you. This seems like we make a good team. So every time we get together, we get to talk about something exciting that's happening.
And
so watch out, people. If we are together, we're bringing you some hot topics here.
And there's always something. So
yeah.
Semaglutide seems to be absolutely everywhere.
Mm-hmm.
And so let's start with just the basics. What exactly is semaglutide and why has it become actually transformative? It's a transformative medication in both diabetes as well as obesity care.
Yeah, that's right. Transformative is the right word to use. So semaglutide, for people who know this as Ozempic or Wegovy. So the technical name is semaglutide. It's what we call as a agonist of a naturally produced hormone called GLP, or glucagon-like peptide 1. So it was initially developed for type 2 diabetes and showed really a promise in improvement in type 2 diabetes. So one of its superpower is it increases insulin production, but in a glucose-dependent manner. What I mean by that is that, so our pancreas senses blood sugar, and if the blood sugar is rising, insulin is produced. When the blood sugar goes down, the insulin production is shut off. Now, most of the insulin secretagogues, meaning like our old sulfonylureas, people know it as glipizide, glimepiride, they do not have that glucose sensing. So they continue to produce insulin irrespective of what glucose is. So that's why there is a risk of hypoglycemia for many of them. And obviously for insulin, if you give it from outside, it's not shutting down. So however, when GLP-1 agonists, the semaglutide, when it stimulates pancreas to secrete insulin, it does so just exactly like our pancreas does, only in glucose-dependent manner. If the blood glucose is going down, it does not release insulin. So that's its major superpower. That's why it was so transformative for diabetes management. The other thing it does is that it decreases glucagon production. Glucagon is one of the hormones that increases glucose production from our liver. So that's an important mechanism to protect against low blood sugars when you're not eating. But in patients with diabetes, the glucagon secretion causes abnormal increase in glucose in the blood. And apart from that, it also decreases gastric emptying time, meaning that the food stays longer in the stomach. Again, this is more early effect when you take GLPs, but making you feel fuller longer, so decreases the food increase and also increases satiety. It also has effects on the brain, increases satiety and decreases hunger, so acting on the central appetite pathways. So all of this resulted in an enormous improvement in diabetes as well as weight. So the older obesity drugs, as you know, they caused about anywhere from 5 to 8% weight loss. So when the STEP trials, those are the trials, the program where the semaglutide was evaluated for its weight loss effects in different variety of populations, average weight loss was about 15%, which was the first time a drug has shown double-digit weight loss. So that was, a very, very transformative. So
it's got some true safety features built in there too.
Yeah,
I mean, that's really a critical piece of this as well.
Yeah.
So many clinicians, they know the names, Ozempic and Wegovy, Rybelsus even, but sometimes there's confusion about how these differ. And so can you walk us through semaglutide, the family of them maybe, and what
Yeah.
would be the indications for the different formulations?
Yeah, these are many avatars of semaglutide, So the semaglutide, the first, it came out as Ozempic, right? So the Ozempic was approved for type 2 diabetes, and the doses went initially up to 1 milligram, and then it went up to 2 milligrams. And then when the STEP trials came out, so it was approved for obesity. So even if you didn't have diabetes, you could, and it was given the name Wegovy. It's exactly the same drug, but the dosages kind of differed a little bit, and the highest dose was 2.4 milligrams. And then Rybelsus, which is a oral form of semaglutide, we'll talk a little bit about that, the oral forms. So that came about and was approved for diabetes up to what we call as 14 milligrams. And then the Wegovy high dose came about, which is the original 2.4 milligrams apparently is no longer enough. Or at least it's safe to increase the dose. So the 7.2 milligrams of injectable Wegovy came, that's Wegovy HD. And then oral Wegovy came as Wegovy pill. It's the same Rybelsus we talked about that's approved for diabetes up to 14 milligrams. Now the Wegovy pill, the same semaglutide, is up to 25 milligrams. So there are 3 formulations for obesity and 2 formulations for diabetes. So Ozempic is an injection for diabetes. Rybelsus is a pill for diabetes. Wegovy injection for obesity. Wegovy HD high dose is an injection for obesity, and then oral Wegovy is a pill for obesity.
Okay.
So it's the same.
It's helpful to put those into those classes so we order it for the right reason, or we risk a denial. So that's important.
Yeah.
So, and one of the reasons semaglutide has gained so much attention is that impressive effect on the weight loss. So there are some major clinical trials that have taught us a lot about that weight loss. So what can our patients realistically expect? What would you think?
So the STEP program is the one that gave us that impressive weight loss, right? So I think the STEP 1 that showed about 15% average weight loss with a 2.4 milligram daily dose. So that is a trial in which the patients had obesity but did not have diabetes. I think one of the things that people do not realize is that semaglutide overall results in less weight loss in patients with diabetes. So it's not just semaglutide, it's all the GLP-1 class. So the amount of weight loss is a little bit less. So for example, STEP 2 trial where the Wegovy was used in type 2 population only showed about 9 to 10% weight loss. So again, this is a very fascinating phenomena which we don't know why this. I mean, it's been shown in trial and again why patients with diabetes have lower weight loss compared to patients without. I mean, one thought is that diabetes itself could be a resistant state to GLP-1s because, we do have a native GLP-1. At one point there was thought that the patients with type 2 diabetes develop diabetes because GLP-1, maybe they're resistant or less production. This suggests maybe there is some resistance to GLP. So again, all the trials prove it. So that's one. There are other, you would see them in as Ozempic as well. The STEP program is just the highest dose of Ozempic, semaglutide we saw as 2.4 milligrams. We'll come to the high dose Wegovy a little bit because I want to just keep to our original ones. In the Rybelsus program, there was a weight loss of about 3 to 5%, not very much. Again, these patients are all patients with diabetes, the oral semaglutide that was shown, and the dose only went up to 14 milligrams in oral terms. So there was, and then the oral Wegovy showed about maybe 12 to 14% weight loss with the 25 milligrams. Now, it's not as much as we saw with just the injectable, which was 15+%. The oral ones showed a little bit less, but still they're pretty impressive. And even among diabetes patients, even if they're not as much as in non-diabetic patients, still about double digit, like 10% weight loss.
And there's no insulin when they're looking at these patients with diabetes. It's not an insulin in the background that is keeping that weight up.
Yeah,
preventing.
so it was not. And so patients with diabetes, like even if you look at our dulaglutide trials, I mean, there's not that much weight loss in patients with diabetes.
Okay.
So again, that's something that it's been kind of in the background. I mean, no one has really been able to explain it away.
Okay. And you alluded to the higher dose Wegovy.
Yeah.
So who are the patient candidates for this higher dose?
So it's, I think one of the things many of you in clinical practice may have noticed, patients don't have the same effect as we continue to use the drug. So now many of our patients have been on these drugs, the ones who are taking it continuously 2, 3, 4 years, and now they're kind of stalled, or the weight is creeping back up because there is some tolerance. So the patient's amount of food intake will come back a little bit. They're no longer feeling as much nauseous or something like that. Variety of reasons why the weight can come back, and they're actually tolerating well, right? They don't have any side effects. So it's those people who are they able to tolerate the highest dose Wegovy very well and still have more weight to lose. So those are the ones that you would recommend the high dose Wegovy of 7.2 milligrams.
Okay.
Yeah.
Right.
And so I think that's the trial that was called Step Up trial. I mean, this is all kind of I don't know how they come up with these names, but it's really messing with my brain with all the names. But the Step Up trial was the one where they showed about 20%. I've said that the 2.4 milligram dose was about a weight loss of about 15%. So I think this was an attempt to get it closer to tirzepatide, which we'll talk in future episodes, which has about 20% weight loss. So that was the reason why this was done. And, again, this is a natural hormone. There is no higher, it's not there's no max dose, I think. Obviously, it's something that if the side effects are a limiting factor, I mean, that could be a significant issue. We'll talk a little bit more about side effects, but I do want to bring up one thing that is somewhat unique to this drug, which is dysesthesia. So you may have heard, 1 or 2 people, like I have a couple of people in practice who complain about this burning sensation, numbness, skin sensitivity. That, initially it was not really, I was surprised, and, there were little case reports or some blogs that people were complaining about it, but that laid bare to this side effect of dysesthesia in this very high dose Wegovy trial. So the incidence of this symptoms is about 22% in patients with the 7.2 milligram dose. It's only with placebo, it was 0.3. And then with even 2.4 milligram dose, it was only 6%. So, but the thing is that as the dose was reduced, most of these patients, the symptoms improved or went away. So it was also seen with oral Wegovy, believe it or not, but 5%. And I think so it's important to keep in mind, don't do what I did. It's like, maybe I'm like thinking, is my patient imagining this? I had not read about this, but this was a while back. But now we know that it is real, and dose adjustment might help. So it might lead some people to permanently discontinue. So.
Thank you, Dr. Kidambi, for joining us today and sharing your insights on semaglutide and its evolving role in diabetes and obesity, and certainly more to come in a future episode. And thank you, listeners, for joining us in this episode of Endo Bites, Bite in Time. Until next time, stay curious and keep learning.
Thank you. Thank you, Kate.
Thank you.